Hello, welcome to DPT 631 Musculoskeletal 1. Now that we've reviewed the anatomy for the wrist and hand, we're going to talk about clinical syndromes and diagnoses that you might see in the clinic that come through the door that you're going to need to evaluate and treat. So we're going to talk through these different clinical syndromes, how to diagnose them, and then how to treat them. Oftentimes in the wrist and hand, it becomes a surgical problem, or it can become a bracing or stabilizing problem. So the first thing we need to look at is the different things we might see. Carpal tunnel syndrome, triangular fibrocartilage complex injury, de Quervain stenosynovitis, CMC osteoarthritis, Colles fracture, scaphoid fracture, Kienbach's disease, ulnar tunnel syndrome, also known as Guillain Canal syndrome, and ulnar collateral thumb ligament injury. There will be a second PowerPoint on further diagnoses that aren't going to be discussed in this one. So the first one and the most common one is carpal tunnel syndrome. It's compression of the median nerve as it enters into the hand. Most common upper extremity compressive neuropathy. Typically, women are affected more than men. Occupation that involves repetitive tasks, diabetes can also be a part of it. If you look at the picture to the right, some of the common complaints might be waking up at night with some tingling, pain in the thumb and the index and middle finger. People may have progressive numbness, maybe as they're driving and putting compression on that nerve. And you may, in later stages, they may complain of weakness in the thumb. That can play a role in this as well. So typically, you're going to find this in people that are over 45. They're going to complain of numbness and tingling in the past. Typically, it's going to be intermittent, not all the time. Nocturnal symptoms, they wake up at night with it. Shaking of the hands improves the symptoms. It can be bilateral. Usually they diagnose this through an EMG study. That's typically how they find out about it. But it can pretty much be diagnosed clinically as well. The EMG is just going to really confirm what you're already thinking. So if we use a body chart, where they're going to feel it is that thumb, index, and middle finger. That's the median nerve distribution. They may have limited range of motion, especially with wrist extension and flexion. Abductor pollicis brevis weakness would be the big one that you would notice. So if you go back to look at the anatomy review, that abductor pollicis brevis is going to be weaker, so you can manually muscle test that. You could also do some pinch and key grip testing, which we'll talk a little bit more about, as well as just standard grip testing, which we'll talk further about in the evaluation video. And then we have some special tests to help rule it in or rule it out as well, which we'll talk about now. So upper left-hand corner, this is called the Phalen's test. So the individual seated, and they let their wrists flex into a position, and they hold that there for up to 60 seconds. If they start to get numbness, tingling, pain in the thumb, index, middle finger, that test would be positive. We also have the reverse Phalen's position, which is wrist extension. So you have them put their hands on the table, and they hold that for 60 seconds. If that reproduces symptoms, it's positive. So both of those, either maximal flexion or maximal extension, and it is held. If any of those are positive, that would be positive for carpal tunnel. The flick maneuver, if they come in and they have to flick their hands back and forth, and that relieves their symptoms, that would be a positive test. We also have the percussion test or Tonell sign, where we tap on the median nerve. If that reproduces any signs or symptoms, paresthesia, that would be positive. Also, we have 2-point discrimination. So with this compression, they can start to get numbness and not feel as much. If they cannot feel a distance of more than 6 millimeters, that would be positive. So we can use 2-point discrimination. We can go through that in lab as well. And then monofilament testing. If in the median nerve field, they should be able to feel up to 2.83 milligrams of pressure. We have the Simmons-Weinstein monofilament test in the lab as well that we can go over in lab. Carpal compression test. So this is where you just press on that carpal tunnel for 30 seconds. So these are some of the tests we can do to help rule in or rule out. We also have the wrist ratio index. So this is basically someone with a thick wrist in the AP direction. That is going to be more likely that they're going to develop or have carpal tunnel. So people kind of get a little confused about this. Think of the people with the big, thick, round wrists, not the wide ones in a medial to lateral direction. So if you think about, you take the anterior to posterior divided by the medial lateral. So let's just say your medial lateral distance is 10 centimeters. I'm just throwing out a number that's easy to do in math. If their AP is close to 10 centimeters, 9, 8, 7, that's a fairly thick wrist. And what that tells us is they got a lot of stuff going through that carpal tunnel and there's not a lot of room there. So if you've got a big A to P wrist, that's a lot of thickness, a lot of things in a small amount of space. That would be more positive. So that's the wrist ratio index. You also just have general inspection for thenar atrophy. So if you see that, that would indicate that maybe there's a carpal tunnel syndrome going on. So here is just a video that just shows you this, which isn't going to play. But it is just showing you do the wrist ratio index. We will go through this in lab. We also have Tinel's sign, which we discussed, which this isn't working, but we'll go through in lab. Phelan's test, and we also have reverse Phelan's. Those are just videos showing it. So they came up with this clinical decision rule, or basically a clinical prediction rule. So they just looked at people that were positive with carpal tunnel syndrome and what factors helped determine those that had it. And so, you know, they did all these historical questions. They examined all these different things. They asked about their symptoms, and then basically they did an EMG to determine who had it, and then they went back and looked at all these people that have it. Is there any common signs or symptoms? And so what they found was people over 45, shaking of hands relieves symptoms, wrist ratio index greater than 6.7, reduced median sensory field to that first digit, so that's that Simmons-Weinstein testing, and symptom severity scale, which is sort of like a Oswestry or an NDI or some of these other outcome measures that you would see. If they were more than 1.9 on it, you can Google the symptom severity scale. You can look at it. If they had more than 1.9, if all those 5 were there, they had a positive likelihood ratio of 18.3, which is a very large shift that they have carpal tunnel syndrome. If you have 4 of them, the likelihood ratio is just 4.6. So something to think about there. So what do we do for people with carpal tunnel interventions? Often what is done is a wrist splint, especially at night, where you put them into slight wrist flexion, slight ulnar deviation. The thought is to help unload that region a little bit, try to modify it, give them a little more space. Activity modification, maybe it's you shouldn't be working on the assembly line. Maybe we need to think about how you're sitting at your computer. We need to modify workstation. They may inject cortisone into the area. Nerve gliding exercises, carpal bone mobilizations, tendon gliding exercises, and even thinking up more of the kinetic chain into the elbow, shoulder, scapula, neck. Is there any impairments in those areas that we can see that might be beneficial to treat? So just a couple studies. You'll see in the left, those are 5 discrete positions for tendon gliding exercises. So an exercise you could give them to glide the tendons that run through that carpal tunnel, the flexors. You start in a straight hand and then you move into a hook hand. You then move into a fist, a tabletop, and a straight fist. And you move through these positions, and these are mobilizing those flexor tendons in the carpal tunnel syndrome. So this has been found to have some efficacy, some effectiveness of treating carpal tunnel, is working on these tendon gliding exercises. Now, in the pictures to the right, here you have more median nerve gliding, and not our typical median nerve gliding that we talked about at the elbow in surface anatomy, but this is more local median nerve gliding. So you start in a fist position, move into a straight fist, extension, extend the thumb, and then add overpressure of that thumb is thought to mobilize the median nerve in there from a local perspective. No, in this study, they looked at median nerve gliding versus tendon gliding. No significant differences between the two groups, but however, both groups had significant improvements. Another small study looked at comparing carpal bone mobilization, neurodynamic mobilization for carpal tunnel. And basically what they had was that either neurodynamic and carpal bones mobilization did better than the control, which was no treatment, but they had the same outcome. And so we should probably use both. We should probably be mobilizing those carpal bones. We should be doing some neurodynamic mobilization, as well as some other exercises to look at treating carpal tunnel. Here was another study just recently, actually, in the Journal of Orthopedic and Sports Physical Therapy. It was the effectiveness of a manual therapy versus surgery on self-report function, cervical range of motion, and pinch grip. So surgical intervention is sort of your gold standard for carpal tunnel, but I think we need to go through and do a good conservative trial treatment, 6, 8, 10 visits of conservative care before surgery. So what they looked at here was the manual therapy group and the surgery group, and compare the outcomes. If you look at the outcomes, the manual therapy is in blue, the surgery is in orange. Pinch grip, so pinch grip force, thumb to index finger, they're at 1 year, they started out the same. So pre-intervention, they had about the same poundage of pinch grip. You look out at 1 year and they all improved, but you notice that there was even a little bit more improvement in that manual therapy group. And then you also, in the upper right hand corner, you have the pinch grip force, thumb to little finger, and you can see they started the same. Obviously that initial dip is probably coming out of surgery. They're going to be weak, they've had trauma, swelling. But if you look at a lot of these outcomes on pinch grip, there's no difference up to 1 year. So you think, maybe we can really get behind this from a PT perspective, and we can treat people for this, and they might not have to go through a surgery, and the expense would be much less to go through therapy than through surgery. So something to think about. This was an RCT. So what did they do in this study? Well, they did a lot of manual therapy, and they didn't just do it at the wrist and hand. They did it the whole way of the nerve, that whole median nerve, which comes out of the neck. So we have up in the upper left corner, they did cervical mobilizations, which we'll talk about in musculoskeletal too. They stretched the scalene muscle where the nerve comes out of the neck. They did mobilization, you know these from surface anatomy, posterior to anterior mobilizations in the mid-cervical. Here they're doing a transverse stretching of the area in the axilla where the nerve and pectoralis would be located. And they even did techniques down into the elbow extensors, pec minor, transverse bicipital aponeurosis, where the median nerve would kind of run under there, all the way down into the forearm. So they really followed that nerve the whole way. And then they did some stretching of the carpal tunnel. So this is just sort of stretching, opening up and stretching that transverse carpal ligament. Here is some manual compression of those lumbrical muscles. And then down below, they stretch the palmar aponeurosis by stretching out that hand, index finger, and really opening up that space. So these are some techniques that we could use. And then for home exercise, they gave him some stretching, neck stretching. So something to consider, not just treating the nerve locally, but treating the whole range. And you may find impairments up into the neck and into the shoulder, and follow where that nerve goes and treat some of the soft tissue around the nerve. So surgical interventions, typically it's a fairly non-invasive. Really all they do is they open up the wrist, they snip the ligament, release it, and let them go back. So they just have a little bit of an incision there. Typically, indications for surgery, you're going to have some atrophy, so it's been chronic long-term sensation loss, symptoms a long time. People that get surgery tend to do fairly well. So that's usually been what people have done. However, we may not need to be jumping to surgery on some of these if people can be patient and work with it. So triangular fibrocartilage complex. So this is, we talked about a little disc. It's almost like a meniscus in the knee. People that have this, typically I think of younger people, gymnasts, they may have fallen on an outstretched hand. They have localized swelling and pain on that ulnar side of the wrist. So if you look at a body chart, they're going to have pain on that ulnar side. They're going to have decreased radial and ulnar deviation, and some pronation, supination. Could be painful to palpation. So we do have some special tests that we could do. We have the ulno menisco triquetral dorsal glide, where basically we're stabilizing and we're providing a dorsal glide of the piezo triquetral complex while stabilizing at the ulna. If they have pain or laxity with that, we'll go over this in the lab, that would be positive. Supination lift test is where they just put their hands under a table and they lift up 90 degrees. I just did that on my table right now. And elbows flex 90 degrees, supinated. Pain on that ulnar side would be positive. So that's supination lift test. You may also have them do the chair lift test. So have them with a chair with armrests, have them push up into it using their body weight. If they have pain loading into that, that would be positive. So as I mentioned earlier, gymnasts, loaded wrist problems, pain and weakness with grip. These are people that have been diagnosed with this. Let's talk about, again, axial load. You can have traumatic tears, you can have degenerative tears. You can get some chondromalacia of the bones, the carpal bones, and the ulnar space there. Interventions, what do? You treat the impairments. You may have them brace it, and then post-surgical, they'd go in and arthroscopically debride it. I've never seen anyone with a diagnosed TFCC injury that's come into physical therapy, but that's something that you could possibly see down the line, so I want you to be aware of it. De Quervain syndrome is inflammation of the extensor pollicis brevis and adductor pollicis brevis in the thumb. So if we look down at this picture down here, we've got this nice tendon sheath, and we've got the extensor and abductor pollicis tendons. So what you see here is sort of a tenosynovitis, or an inflammation around the tendon area. And typically they feel this burning tendon sensation on that radial side of the wrist. Usually they're female, over 40, and they have pain with abduction, pain with a grip, and they may have some pain with extension of that wrist. So that's de Quervain syndrome. I want to say somebody in last year's class had this. And what they're probably going to do with them, before we get to that, let's talk about bracing it. Or let's talk about the special test. Special test is Finkelstein's test. Finkelstein's test is, it's not very specific. You get a lot of false negatives. So what you do is you bring your thumb, kind of like you're doing the radial nerve glide test, where you get your thumb in there and you do pronation, and that's how you test radial nerve. You put the thumb into the grip, and you have them ulnarly deviate. And that's going to put a decent amount of tension on that abductor pollicis longus and extensor pollicis brevis. So here you've got extensor pollicis longus down through here, and here you've got, abductor pollicis longus and extensor pollicis longus right through here, and this is extensor pollicis brevis. So these two tendons is what you're going for. The extensor pollicis makes up the other side of the snuff box. We'll talk a little bit about the snuff box. So it's these tendons on that lower side, on that underneath side of the snuff box. Finkelstein's test is usually what we use. It's not a great test, so often we're going by signs and symptoms. Here's a picture of Finkelstein's, which I will show you in lab, which is not working at the moment. What do we do with these folks? We often put them in a brace like this. We do rest, we do ice, we might do low pulsed ultrasound. I don't know what the evidence is for that. Put them in a thumb spica. Once the symptoms have calmed down, we're going to start some progressive strengthening exercises. We might start with isometrics, concentrics, and eccentrics, and just do general wrist strengthening. So this was a case report in Journal of Orthopedic and Sports Physical Therapy. It sounded like this was a patient that had that burning pain, pain similar to de Quervain syndrome. And so what they did was they did a manual therapy approach where they mobilized the wrist, AP glide, an ulnar glide, a radial glide, and have them do that at home as part of a program, and that seemed to help their symptoms. Although it's a case report, we can't specifically say cause and effect relationship. Okay, so another common syndrome problem that you might find, similarly to how we get arthritis in our knees, hips, shoulders, we can also get this in our PIP and DIP joints. We don't do much in the PIP and DIP joints of the hand, but hand is where you tend to see a lot of arthritic changes. If you just look at maybe an elderly person, you're going to start to see some deformity in the hand. So that's a common place where arthritis sets in. We don't treat that very much in the DIP and PIPs, but they may have these swollen bulbular joints, which can occur. However, we're probably maybe a little bit more concerned with the carpal metacarpal joints, the thumb. This tends to be treated a little bit more in physical therapy practice, occupational therapy, than the PIPs and the DIP joints. But typically people with use their hands a lot, manual laborers. Chris Kinslow has sort of noticed this with some of his patients. When he applies his hand on their back, he pushes down. He has a little sensitivity around the CMC joint. He thinks that maybe it's from doing some manual therapy over the years. So we need to be really careful with our thumbs. The thumb is a small joint. We put a lot of load through it doing manual therapy techniques. Over time, that's going to wear us out if you're going to have a 30, 40-year career. So we have to be careful about our thumb. Often it's female, older age in life, a lot like osteoarthritis, 50s, 60s, 70s. You start to maybe get that. History of occupational use, decreased thumb range of motion, decreased grip strength, increased pain with gripping is what you might find in this population. This is going to be a little different than de Quervain's. You're not going to really have the burning numbness. They're not going to have a positive de Quervain's test. There is really no special test for this. It's just sort of a, other than an x-ray that's going to show degenerative changes, it's more of a clinical diagnosis. So what do we do? How do we treat these individuals? So there is some evidence out there. So we can do local mobilizations at the CMC joint, which we'll go over in class. So we can mobilize the thumb. We can also, there's also this study that looked at mobilization of the nervous system, where they did median nerve gliding, and that seemed to help and reduce some of this. You may see some evidence for low-level laser. And then you also can put them in a brace. So if they're going to continue to work and use this thumb, they may need to be braced up to take a little bit of pressure off of it. in that lower right-hand corner, you're going to see they're doing kind of some isometrics of the thumb through here, stabilizing and engaging some of those thumb muscles, pushing in. But you don't want to really put a lot of force through there. You want to gradually progress it. This is another study, same author, I believe, looking at radial nerve mobilizations, decreasing sensitivity and motor performance in patients with thumb carpal metacarpal osteoarthritis. So they did these radial nerve mobilizations, and then they gave them some exercises. So remember the tendon gliding, the tabletop, the small fist, large fist. They had to move into an OK sign, spread the fingers, thumb reach, gripping exercises, key pinch, strengthening exercises. And that seemed to help reduce patients' symptoms. And then up in this corner, you can see them doing the radial nerve mobilizations, which you've learned. So that's cool. And they also, this is the same author again. This guy studies thumb CMC osteoarthritis. I think he's maybe Spanish. But the local mobilization of that CMC joint has apparently has some hypoalgesic effects. So it sort of reduces pain in people who go through these mobilizations immediately afterwards. So thumb CMC is a thing. Protect it, splint it, possibly mobilize it. Think about the radial nerve, the median nerve, and then gradually progress strengthening exercises with it. Just because they have arthritis doesn't mean that they're going to have symptoms. Tissue issues do not equal a pain issue. Just we need to keep that in perspective, keep that in mind. Colles fracture of the distal radius. Colles fracture can stretch into the joint space. So what usually happens is a fallen and outstretched hand disturbs the radial ulnar displacement. So I was talking about the variance in the ulnar and the radial in the first PowerPoint. We need to remember that in a Colles fracture, it could disrupt that, and then that needs to be surgically repaired. Can be a little bit tricky. Usually you're playing film radiographs, CT scan, MRI, pain. Obviously, this isn't something you're going to treat conservatively. They're going to come out of surgery. They're going to be stiff. More likely, they're going to have some sort of screws or plates in their wrist. They're going to be very stiff, very tight, and very weak. So here is the angulation, the angle of variance I was talking about. So when someone falls on an outstretched hand, so that's the radius right there. You can see this. This is going to be kind of your first contact point. So people can damage this and break this area, and it needs to be repaired in that same angle that it's in. So something to consider. Scaphoid fractures are another common thing that you might see on a fall on an outstretched hand. Usually it's going to be younger males. Why? Because they're typically the ones that are out doing more dangerous things that would involve them falling on their hand. Thus, that's a higher population. They're going to have a deep dull ache on the radial side of the wrist. If x-rays are negative, they're going to repeat the MRI. They're going to have mild swelling and bruising. So there's also a clinical prediction role by Duckworth in the British Journal Medicine, JBGS, British, 2012, scaphoid fracture. 4 variables seem to kind of be high predictability that they have a scaphoid fracture: male gender, sporting activity, anatomical snuff box tenderness, and pain on altered deviation within 72 hours of injury. Scaphoid tubercle tenderness. We'll talk about how to palpate the scaphoid tubercle in lab later on. So if all 4 of those are very present, they have a 91% risk of fracture of the scaphoid. Okay. Another way to diagnose these scaphoid fractures are snuff box tenderness, scaphoid tubercle tenderness, longitudinal compression. If all 3 of those are present or not present, if they're all negative, it's 100% sensitive. And if they're all present, they have 74% specificity. So snuff box tenderness, scaphoid tubercle tenderness, and longitudinal compression. So the tricky thing about a scaphoid fracture is that you may have talked about this in your imaging course. They don't always show up on x-ray. But you suspect a scaphoid fracture, they have an x-ray, no fracture seen. They still have pain up to 2 weeks later. You may need to do an MRI. If it's abnormal, you would then maybe cast it or see if they need surgery. If the fracture is visible, you want to know if it's displayed or undisplaced. If it's undisplaced, the CT scan may have a better idea of indicating if it's displaced or undisplaced. So they may end up doing multiples, but MRI seems to be pretty good, ruling out and ruling in. But if they have the pain, they don't see a fracture on x-ray, they're still probably going to splint them. This isn't someone that's going to come into PT, but if you're direct access and they come in, they're like, yeah, I fell on this wrist a long time ago, I went to the ER, they did an x-ray, it was negative, they sent me home. Then you might need to think that, well, you still could have a fracture, you might need some more imaging. So you'd have to probably refer them out. So what are some special tests we use? Anatomical snuff box tenderness. So the snuff box is in here. We palpate that, it's painful, or we load the thumb with scaphoid compression. That would be positive. There's anatomical snuff box tenderness. There's scaphoid tubercle tenderness, so that just sits a little bit lower. If somebody has pain down there, that would be positive. And if you keep them in pronation, have them ulnarly deviate, and that's painful, in the snuff box, that would indicate a scaphoid fracture. Radial deviation of the wrist, same thing, pain with that. This is supposed to say Kienbock's disease, K-I-E, and that's got some kind of weird symbols above the E. I'm not sure what language that is, but Kienbock's disease. I should back up about scaphoid fracture. One thing we need to think about with scaphoid fracture and why it's important is they can develop avascular necrosis of the scaphoid. So we don't want them to get AVN. It usually does come back, but that's why imaging is also important with that. But Kienbock's disease is an avascular necrosis of the lunate in the proximal row. Could be triggered by a fall on an outstretched arm. The lunate has limited blood supply, so usually they would need to be splinted, and usually this will come back. But that's Kienbock's disease. You're not really going to do much in therapy if they send you to Kienbock's disease. After this, you're just going to look at the impairments. What's their range of motion like? What's their strength like? And just build up their range of motion and strength over time. Graded program. Ulnar-Guillen's canal syndrome. This is what I mentioned in the anatomical review video, is that on the ulnar side, you can get some burning, tingling, numbness just medial to the pisiform. You can palpate that area. You may also need a differential diagnosis from a C8 radiculopathy, so you have to do your neck testing, your nerve testing, compression test, Sperling's test, distraction test to differentiate the two. So we also have Tinel's sign for Guillen's canal, which we would just tap over that area, which we'll go over in lab. Another diagnosis we get is gamekeeper's thumb or skier's thumb. What it really is an injury to the ulnar collateral ligament of the thumb. So you're going to valgus stress test that ligament, which we'll go over in lab. If they have pain or laxity, that would be positive. What are you going to do? You're probably going to splint them in a thumb spica to protect the ligament. And then over time, once that ligament scars out and heals, you're going to go through some progressive grip strengthening and thumb strengthening. Okay, so that does it for hand interventions, evaluation of specific disorders. We will continue this discussion later on, and we will talk to you later. Bye. Thanks.